Chapter 7, Psychotherapeutic Drug Therapy. How does psychotherapeutic therapy work? These medications, they act on the body's nervous system primarily by altering the delicate chemical balances within the system. So it's actually affecting the chemical messenger, the neurotransmitter, the dopamine, the norepinephrine, the serotonin. Those are the ones that this medication is actually altering. And those neurotransmitter pathways also that is within the brain to actually kind of like help manage symptoms. A primary responsibility of healthcare provider, especially nurses, is to differentiate therapeutic from unwanted effects. So because these medications are actually affecting the nervous system, and the nervous system is responsible for a lot of things in the body, a lot of functioning in the body. Because it's altering that, you are going to have unwanted side effects. Okay, so we would want, the goal is to make sure that the medication we're giving is therapeutic, but also monitoring for unwanted side effects. Those are the primary goal of healthcare providers, especially nurses, when we're actually giving this psychotherapeutic drug therapy. The frontal lobe and the limbic system, I just want to mention because these two things are also being affected when we are actually talking about mental health and the psychotherapeutic drug therapy. Frontal lobe is responsible for higher human functions like loving, creativity, insight, planning, judgment, abstract reasoning. The limbic system is responsible for emotions, motivations, memory, and the fight or flight response. Okay, this part is very important. There are four classes of psychotherapeutic drugs. Okay, hold on. Four classes of psychotherapeutic drugs. Psychotherapeutic is the umbrella, right? This one right here. Okay. Consider this as the umbrella of these classes of the medications. Under your psychotherapeutic drugs is anti-anxiety, antidepressant, anti-manics, and antipsychotics. Again, psychotherapeutic drugs is the big umbrella. Under the psychotherapeutic is anti-anxiety, antidepressants, anti-manics, and antipsychotics. So do not confuse antipsychotics with your psychotherapeutic drugs, okay? Or your psychotropics is what we call it, psychotropics. Antipsychotic is different. This is a subclass of the psychotherapeutic drugs or psychotropic, okay? People who are receiving medications, we must monitor them routinely for effectiveness, side effects, and life-threatening adverse reactions. And it's true. These adverse reactions, because they are working with a very important system, your nervous system, it could be life-threatening adverse reactions. So we gotta make sure that we're actually limiting the use of these psychotherapeutic drugs if we can, monitoring them for adverse effects, notifying the healthcare provider right away if we see that there's adverse effects. First up is your anti-anxiety medication. Anti-anxiety agents are drugs that reduce the psychic tension of stress. We call them anxiolytics, or sometimes we even call them minor tranquilizers, because it kind of like helps to calm down. It has that calming effect in the body. Medications in this group are divided by their chemical formulas into categories. Benzodiazepines, this is mainly used to decrease anxiety. And what are those medications? Sample of those medications under this class. Remember your Ativan, your AMS, right? AMS, okay? Lorazepams, your Ativan, diazepams, alprazolam, okay? Those are your benzodiazepine. And what it does is it acts by increasing this GABA, your gamma aminobutyric acid or GABA activity. It's trying to increase it, which results in decreased anxiety and increased calming effect. Your GABA is actually responsible and it produces a calming effect, okay? So if it's being increased, that patient is going to be calm, right? And there will be a decreased anxiety. Because long-term use of anti-anxiety drugs can result in dependence. Okay, can result in dependence. Therapy for clients usually is limited, right? So your benzo is one of those medication that can actually result in dependence. So what we do is we actually try to limit it, try to limit the time that we use this medication because we gotta be very careful. More anti-anxiety medication is your buspirone or your buspar. This one belongs to the azaspirone drug class and it does not cause the sleepiness or muscle relaxation that is associated with the first one we did talk about, which is your benzodiazepine. So it helps with anxiety, and it doesn't cause sleepiness and that muscle relaxation that is associated with the benzodiazepine. However, the problem here is that therapeutic effects is not seen for 3 to 6 weeks after treatment initiation. So it takes 3 to 6 weeks before we can even see that effect. So if you have a patient that's having a manic episode, for example, or having some increased or severe anxiety, having that panic attack, maybe being aggressive even, this medication is not good for to use for that. It's not something that you could use for acute and rapid acting, right? You're gonna want to use your benzodiazepine, which is your lorazepam and your diazepam, because those are actually rapid acting. If you give it, it will have an effect right away. Your buspar, you're not going to see the therapeutic effects until 3 to 6 weeks. So we use benzo to kind of like stabilize a patient that is having an acute crisis, and then boost bar is actually something that we give if we want to kind of like prevent them from going into that anxiety state again. Okay. Then you have your pregabalin or what we call Lyrica. The side effects are fewer than those of other anti-anxiety drugs, so the patients are more likely to comply with treatment. But just like your Buspar, it's the same thing. It doesn't give that immediate effect that we need when they're having that acute or crisis event. Interactions with the anti-anxiety medication is the central nervous system depression. Central nervous system depression. This medication is causing that, so you do not want to combine it with another CNS depressant, like maybe alcohol, right? You don't want to combine this medication with alcohol because they both depress the CNS. Also, this medication can increase the concentration of the cardiac drug digoxin. Digoxin is lowering that heart rate, right? And increasing that cardiac contractility. However, if you actually combine it with the anti-anxiety medication, it's not good because both of them are actually depressing that CNS, maybe depressing those respiratory system too. And next thing you know, the patient will be harmed. Also interfere with absorption into the bloodstream when taken with antacids. So if the patient actually has an order for an anti-anxiety medication and antacid, you want to space them apart, right? You don't want to give them together because it interferes with the absorption of this medication if it's taken with antacids. So you gotta wait, right? 1 to 2 hours apart from your antacid and the anti-anxiety medications. Okay, some patients do not want to continue this medication because of the negative side effects, like they're going to be sleepy, they're going to be drowsy. So if you have patient that is actually up and about every day in the morning and they have to go to work and or they have to go to school and they have to be awake, so you're going to have patients that will be non-compliant with this medication because of the side effects of being sleepiness and all of those things that is going to be making them hard to be able to function in the everyday activity daily livings. Antidepressant medications, now this one also act on the body by increasing certain neurotransmitter activities like the monoamine oxidase, your serotonin, right? Norepinephrine, okay? The physician's first choice for the treatment of depression is often an antidepressant. And antidepressants are divided into categories. You have your TCA or your tricyclic antidepressants, monoamine oxidase inhibitors or your MAOIs, selective serotonin reuptake inhibitors or the SSRIs. We have atypical depressants or your selective serotonin or norepinephrine reuptake inhibitors or your SSNRIs. Okay, in page 69, your table 7.2, these are the list of the anti-anxiety and antidepressant medications. So it's talking about the drug class, the name of the medication, what it's for, an example of the medication, and the nursing intervention that we have to do for the patient. So highlight this box, make sure you study this box, okay? Antidepressant medications may be taken 1 to 4 weeks before symptom relief is noted. What's the relevance of this? Well, if you're doing education or you yourself as a nurse that is monitoring the effectiveness of the intervention that you do for the patient that has a depression, you're not going to expect that the effect is going to be there right away, right? Because, like we said, it may be taken 1 to 4 weeks before a symptom relief is actually noted. It's going to take some time before you can even see the effect of these medications. Side effects are including your dry mouth, nose, and eyes, urinary retention, and even hypertensive crisis. And we'll talk about MAOIs in a little bit combined with foods that could actually cause that hypertensive crisis. These discomforts can be so bothersome that some people refuse to take their medications regularly. However, it's a side effect of the medication, right? We could actually manage that. For example, your dry mouth. What can we do for dry mouth? We can do oral care. We can give them those hard candies to kind of like help with the moisture of the mouth. Nose, you can have those saline sprays, right? Eyes, you can have those artificial tears, okay? MAOIs have many drug and food interactions. So that's why I said when you go and study this table 7.2, you look at those medications, especially those MAOIs, and kind of like pay attention into what are the nursing intervention that we need to do when we're giving these medications. Maui's, if combined with food that is containing tyramine, right? If you recall tyramine, let me write that down so we can remember it, right? Tyramine, okay? You do not want this, okay? You cannot combine this with this medication MAOIs because it can cause right here your hypertensive crisis. Okay, so what are those food that actually need to be avoided when you're taking monoamine oxidase inhibitors? Well, they are in page 71, box 7.2. Foods to avoid: your alcoholic drinks, beer, ale, red wines, sherry wines, liquors, cognac, and then you have dairy products, your aged cheese, sour cream, fruits and vegetables, your avocados, bananas, fava and broad beans, canned figs, any overripe fruit, your meat, which is pickled or smoked, your bologna, chicken or beef liver, dried fish, meat tenderizer, salami, sausage, other foods with large amounts of caffeinated coffee, tea, or cola, chocolate, licorice, soy sauce, and yeast. Okay, so please highlight this box too and know the medications to avoid and know the foods to avoid when you're taking the MAOIs or MAOIs. Also, in addition to this, please remember that your patient that is taking an antidepressant, we have to monitor them for the increased risk for suicide. Okay, how ironic is it that we're trying to actually help them with the depression, but one of the side effects of starting a patient with an antidepressant is actually the increased risk for suicide. So once you start giving this their medication, make sure that you're actually monitoring the emotions and the behavior of the patients and make sure that we're actually addressing if there's any ideations for suicide. Okay, all right. Anti-manic medication, one of them is lithium. This lithium is a naturally occurring salt that is used to treat the manic phase of the bipolar disorder. All right, there's two bolts for bipolar, just really quick, right? You have the ups, right, and the downs. And what are they? When it's up, then they call it manic or mania, right? And then when it's down, then the patient is actually very depressed, right? That's the two poles of your bipolar is mania and depression. Okay, lithium is good to actually control or manage this episode right here, or that pole right there is your mania. Well absorbed into the bloodstream and excreted faster than sodium by the kidneys. So important thing to remember for your lithium is the patient needs to have that balance there's with the salt intake. The patient needs to have that balance with the salt intake and fluid intake and activity, but focus on the salt intake. Okay, um, what happens is that when there's a decrease of this salt or the sodium level in the body, your lithium is actually going to your lithium level is actually going to be up. Okay, and you don't want that lithium level to go up because up meaning it's going to be in the toxic level, and we have to monitor patient for the lithium toxicity. It could be really bad, and we'll talk about that in a little bit. Lithium toxicity, okay, it could be really bad. that it could actually cause seizure, coma, or even death, right? Okay, levels that we need to remember, levels higher than 1.5 levels, sorry, levels that is higher than 1.5 are considered toxic. Okay, levels higher than 1.5 are considered toxic. Clinical improvement will commonly take as long as 3 weeks. So another drug that we will use that we don't actually have to see an effect right away, but it could actually take even as long as 3 weeks before we can even see the effect and the therapeutic effect. Okay. All right, antipsychotic medications. Antipsychotics are also called major tranquilizer, or sometimes we even call this neuroleptics. We use this to treat the symptoms of your major mental disorder like your schizophrenia, acute mania, and organic mental illness, and resistant bipolar, manic depressive, paranoid disorder, and some movement disorder. Your table 7.5 and table 7.6. Again, two box that is very important for us to highlight and remember. Table 7.5 talk about the commonly prescribed antipsychotics. So know their generic name and know the trade name of the antipsychotics. Chlorpromazine, Thorazine, that is common. Fluphenazine is common. Prochlorperazine, haloperidol, very common. Aripiprazole, clozapine, loxapine, quetiapine or your Seroquel, risperidone or Risperdal, and ziprasidone or your Geodone. And then for table 7.6 in page 73, these are the positive and negative symptoms of schizophrenia. And what does it mean? It means positive is something that was not there before, now it's there. Negative symptoms used to be there before and now it's not. Okay, that's what it means. Positive and negative symptoms of schizophrenia. So, like for example, signs and symptoms. The first one, it says type 1 positive symptoms is delusions. Again, something that's not there before, now it's there, right? Type 2 is negative symptoms or the lack of energy. That's why it's called negative symptoms, because the energy used to be there. Now there's a lack of energy. Now it's not there. Okay. So please read through these two tables and know exactly the name, generic name, and the trade name of your antipsychotics, and also the symptoms of schizophrenia. Very important to remember. Okay, extrapyramidal side effects, or the EPS. What is this? This is defined as abnormal movements produced by the imbalance of these neurotransmitters in the brain. This EPS can actually progress to a permanent condition known as your tardive dyskinesia. So what are we gonna do when we start seeing this EPS? Well, we will try to decrease the dosage, right? And then we will switch it to a different medication that could actually, hopefully, will work for the patient. It's not causing that much of an adverse effects. Okay. Now, table 7.7 in page 73, another important table that we need to know. This is your extrapyramidal side effects of the antipsychotics, okay? Extrapyramidal side effects of antipsychotics. Please know them. Please know the name of these signs and symptoms and what is the definition. What actually is for example, akathisia. This is the inability to sit still, right? Akinesia is absence of physical and mental movement, so on and so forth. Especially your tardive dyskinesia, um, irreversible side effect of long-term treatment that produces involuntary repeated movements of muscles in the face, trunk, arms, and legs. Also, your neuroleptic malignant syndrome, very commonly asked. a serious and potentially fatal side effect with unstable vital signs, fever, confusion, muscle rigidity, tremor, and incontinence. Okay? And then for box 7.5, these are drugs or medication that is used to treat EPS, okay? Drugs that's used to treat EPS. Your benztropine or cogentin is the most commonly used, okay? Artane, Inderal, Tonormin, Benadryl, Ativan, Valium, Triazolam, Pramipexole. We can use those medications that is used to treat those EPS when we're giving the antipsychotics. The main thing for your EPS is you don't want to wait, right? As soon as you see that there's an EPS, then you gotta make sure that we're actually notifying the healthcare provider right away. Oh, actually, this is something that we have to monitor routinely, okay? Routinely, you're gonna monitor the patient for this to make sure that we catch it right away and we can do something right away about it, because it could become permanent if there's no intervention. All right. Again, antipsychotic interaction is the antacid. Same thing as the other drug that we talked about earlier on. It hinders the absorption of antipsychotics into the bloodstream. Alcohol you don't want to combine to, because this is another CNS depressant. Anti-anxiety, antihistamine, antidepressant, barbiturates, and your medication mipyridine and morphine, because both produces severe CNS depression when mixed with antipsychotics. Client care guidelines for nurses and those who administer the psychotherapeutic drug. We assess the patient. Okay, after the assessment and the diagnosis, then we make sure we are going to coordinate the care with the IDT team, multidisciplinary team. Then a medication will be ordered, right? So we will administer the medication. After that, like we said, we talk about those medicine that will have that effect right away, and those medication that will actually take some time before it will take effect. So we monitor and evaluate the intervention, the response of the patient to the intervention that we did. And then also we will provide client teaching. Every client has the right to be informed of his or her diagnosis and treatment plan, so the nurses should explain in terms that the client will understand. And this is very important, because sometimes when we do education, we actually use like terms, medical terminology that is kind of like hard for the patient to understand. So when we do those client teaching, we make sure that we're actually doing it in terms that the client can understand it. Nurses should provide information in writing. Um, Antipsychotics or your psychotropic drugs, actually, all of them, you cannot give it to the patient without actually getting a consent first. Okay? Consent, very important. You have to get a consent before you can use these medications for the patients. Because of those side effects that could actually happen, um, you want to make sure that as a nurse, you have that written consent for the medication before you give it. If the patient is confused, for example, and is not able to give you consent, then make sure that you notify the POA. You call a family member and explain it to them. These medications will be given to your family member or to the patient because, for this reason, okay? Non-compliance is an informed decision that is made by the client not to follow a prescribed treatment program. When there is a non-compliance, especially with psychotherapeutic drugs, the physician should be notified. I mean, in any other drugs that we give to the patient, non-compliance, the first step is to always notify the physician, right? The physician needs to know that, there's an order for this patient, and yet the patient do not want to take it. There's a non-compliance. And then work with your patient to find and eliminate the factors that lead to non-compliance. most of this non-compliance, there will be a reason. The patient will be, for example, thinking about the side effects of a certain medication. Little do they know, there's other medications that we can use, right? So work with the patient, ask the patient, assess the patient, interview them, and say, what are those reasons that is actually leading for you to not take your medications? Maybe we can explore it together. Maybe we can think of some alternatives that we can do. Okay? Informed consent. Like I said, this consent presents the patient with information about the benefits, the risk, the side effects of these medications, and it enables them to make voluntary and knowledgeable decisions about their own care. Under the Patient Self-Determination Act, this states that patients have the right to accept or refuse care and cannot be pushed, coerced, or talked into following a certain course. Okay, so let me clarify this. If the patient actually is not a threat to themselves or other people, then yes, this Patient Self-Determination Act is actually going to kick in. They have the right to refuse the care. We cannot push them or coerce them or even talk into following a different or taking their medication, for example. Okay, now, if the patient now becomes a threat to themselves or to other people, then that's a different story. Okay, that there's things that we call involuntary admission to an inpatient care service or something like that. And we will go over that in the next chapters. But for now, please remember that under this act, the Patient Self-Determination Act, if the patient is stable and remains to not be a threat to themselves or others, then we cannot push them and they have the right to accept or refuse care, right? And that is chapter 7.